All right. Well, good morning, good afternoon, depending on where you're calling in from. Welcome to today's AMCHP bi-weekly COVID MCH town hall / policy update. It's hard to believe that when we started this in early April, we thought it was just kind of a 1 or 2 time thing that would be replacing our monthly national policy call. And here we are, I don't know, like 97 months later, or however long it's been. No one's really keeping track of time now, are we? But we're really excited. We have a great lineup for you today. So we'll start with our usual legislative update, which will be very short today. Dr. Warren has joined us from MCHB, and then we're fortunate to have another great presentation about how North Carolina is implementing their COVID Medicaid waiver. Then we're going to hear from Dr. Remley at the National Center on Birth Defects and Developmental Disorders at CDC. A quick announcement about the AMCHP Telehealth project, and then I think a really exciting discussion with the youth perspective on school reopenings. I know we've spoken with AAP on this, but we've spoken with parents, but we haven't spoken yet with students themselves. So that will be the topic of that discussion today. So once again, I'm able to use my slide from July 21st about the virus A talk still being at a standstill. Unfortunately, it does not seem like there's been much progress made. I have heard that the House may be releasing a new version of the bill that they had passed back in May, the HEROES Act, that reflects their sort of next offer coming down from 3 to 2 trillion or so. So that might come out, but nothing is going to pass into law until we have serious bipartisan talks and an agreement, including from the White House. So we're standing by as those continues. And of course, with every day that there's no agreement on COVID relief, we inch closer to September 30th and the end of the fiscal year. So now the COVID relief talks and the continuing resolution talks are still probably going to have to be held in tandem. But that's it for legislative update right now. So I'm going to turn it over to Dr. Warren.
Thank you, Amy. Good afternoon, everyone. So excited to be able to join you again. And to echo what Amy said, when these calls started, I think we all were at least hopeful that they were going to be short-lived. But nonetheless, you all continue to, in so many wonderful ways, meet the needs of MCH populations across the country. So I want to thank you for the wonderful ways you're stepping up. I also want to pause and share our positive thoughts with our colleagues down in Texas and Louisiana, and those who are in the path of what appears to be a fast-moving storm. So hopefully the amount of time we're having to deal with this, at least in the short term, is not going to be bad, but quite a powerful storm. And we've heard from colleagues in both Texas and Louisiana that they're involved in the response. So thank you, and I hope if you've got family or loved ones or others there, that they are safe and well. We will just give a few very high-level updates if we'll advance to the next slide. Last week, we finished what ended up being a 10-week campaign. The intent was 4, and then we thought we'd go to 6, and there was so much interest, we extended it to 10, and that was our Well Child Wednesdays campaign. Some really great reach, and I think that's a testament to the work that you all did in helping to amplify that. Appreciate what states did to amplify that, as well as our other agency partners across HHS and other parts of the federal government. We were also able to get some organizational amplification, AMCHP and ASTHO and AAP. And the Surgeon General even used it as an opportunity to do a couple of videos to talk about immunizations and well child checks. So a lot of energy generated, and the timing is good as it's time for school to start back, and some kids are starting back and some are not. Regardless, we're also heading into the fall and another respiratory virus season, and so it's really important to think about how we get families in the mindset of thinking about getting back in for flu vaccines and also any catch-up vaccines that are needed. So at the departmental level, there's a campaign called Catch Up to Get Ahead. You'll see the hashtag there at the bottom of your slide. And that's continuing through the month of August. As you all know, this is National Immunization Awareness Month. And so a lot of interest across the department in how we support families in getting in for well child visits and immunization. So thank you for a successful campaign. And to the extent that you're able, please continue to promote those messages moving forward. Next slide, please. Just a quick reminder about a few upcoming important dates. You'll know that the block grant application and report and needs assessment deadline was extended from July 15th to September 15th. And so we're getting in the short rows there, a couple more weeks before those are due. A shout out, I think we have 8 states that have submitted thus far, so kudos to those 8. For those who haven't, you still have plenty of time, 2 weeks, so we'll look forward to that. And then following on the heels of that will be the deadline for submitting your non-competing continuation report for SSDI. That was also extended a little bit. And remember, you've got some flexibility if needed in terms of what you report. And if you've got questions, please reach out to our team and we can share some guidance there. That same week, we'll be doing a pre-review webinar for Title V programs to help you understand what the reviews are going to look like. So instead of the in-person reviews, we're doing the virtual reviews this year. Very soon, I think next week, we're going to be doing a training session for the reviewers. Then we'll follow that in September with an orientation session for you all as you look ahead to your reviews. As I think we've shared with you before, the focus is really going to be on the needs assessment and the action plan. There are no bureau topics of interest this year. You know, last year we asked you to talk about several things, including newborn screening and emergency preparedness. We're not asking for those topics this year. 1, given all the other things you've got on your plate right now, and 2, since it's a needs assessment year, we wanted to make sure there's ample time for discussing that. And those reviews will happen between October 1st and December 31st. I see a question in the chat box for the September 24th webinar. Can a link be provided in the chat for registration? I'm not sure if one is available yet, but I will ask our team, Michelle Lawler and her team, to make sure that gets out to you all when it's time to register. If we can go to the next slide. Also wanted to remind folks the call for nominations is open for our annual awards cycle. So both or the Director Awards, but also the Title V Lifetime Achievement Award and the Vince Hutchins Partnership Award. We've moved those online to make it easier to nominate. That was last year was the first time we did it, and we really got some great response. And I think a good example of that is with the Vince Hutchins Partnership Award. We actually recognize some local partnerships, just like politics, public health is local. And so it was great to be able to recognize local partnerships and not just national level partnerships. So that call is open. Folks can nominate on the website, and we would love to get your nomination so that we have a robust pool. And then we'll be talking about how we're going to announce those awards. Usually we do them in person at the partnership meeting, but we will be figuring out a different way to do that this year. And the deadline for those is next Friday, September the 4th. Next slide. That is it. So 2 quick things as I wrap up. 1, it's so good to see my new colleague, Dr. Karen Rimley, see her face. We're so excited. She is at NCBDDD and not a stranger to public health or pediatrics. And so glad to be able to work with her. And Dr. Rimley, it's good to see your face. And also excited to introduce our speaker who is joining us now. You all know I'm from North Carolina, so it's always exciting to get to talk about folks from home. But I'm particularly excited to tell you that Dr. Dowler, who's the Chief Medical Officer for Medicaid, graduated from the Brody School of Medicine at East Carolina, just like I did. So it's nice to have someone with an alma mater connection. Go Pirates! She is going to share with us some great work that they've been doing in North Carolina in response to COVID-19. So I'll turn it over to Dr. Dowler.
Great, thanks. So this is a really high-level quick overview that I'm giving you. I could spend an hour going through all the different data points and slides and the work that we did, but this is really focused on some perinatal telehealth provisions that we made. So next slide. So on March 10th is when our governor in North Carolina issued the executive order for the state of emergency. We had already been hard at work, and our team, as soon as the first cases of COVID happened in the United States, we were already starting to set our path forward on what to make as far as changes with telehealth. And unfortunately, we had a tremendous amount of changes we had to make. Our prior telehealth model was a consultative only model. It was extremely limited and not heavily used. Really pretty much largely used for psychiatry services, a little bit in the telestroke space, but not in the routine care across the board. So we made dramatic and drastic changes in a very short time period. Interestingly, I joined in September of last year. In December, with this Assistant Secretary for Health and Human Services, together we kicked off a campaign to modernize our telehealth. And in our early meetings, it was clear to us that it was going to take us 3 years to modernize our telehealth and to get the legislative and authority and all the things we would need. We were projecting a 3-year pathway. And instead, in 7 weeks, we did everything and even more. So one of the positives of the pandemic was that it really allowed us in North Carolina to jettison ourselves forward in telehealth. Next slide. And so as I mentioned in the beginning, we had one telehealth policy, and it was an extremely limited telehealth policy. And so over a 7-week period, we ended up with a total of 367 flexibilities. 135 of them were telehealth. This impacted 482 billing codes. And of those, we are planning on making about a third of them as permanent changes to our Medicaid program. So we first started with our high priority modifications, then we moved into innovative and creative ideas, and then third, we went to the pure preventive care. We were hesitant to do a lot, especially around well child care, until we understood what the length of the pandemic was going to be. If it was going to be a short-term, quick thing, which we were all sort of naively hopeful for, then we didn't want to do a lot of preventive care. But as it became clear that this was going to be months, if not years, we moved into those changes. Concurrently, and probably really critically important, is we looked at rate changes to support providers at the same time. We started with our safety net providers first, then we moved to long-term care and hospitals, and then broad across the board rate changes. Next slide. So several of the things we did affect our perinatal billing. So we did allow telemedicine for pregnancy care early on. It was probably in the 3rd or 4th round. Every week we would announce a whole new slate of changes, of telehealth changes, as we built the systems. And we'd have to build the IT side and the billing side at the same time. So we were definitely moving very fast. Everyone was working 80-hour weeks, including our vendors, to get this work done. But we included essentially any antepartum or postpartum visits with telemedicine, including the first visit. We continue to allow providers to use global billing codes, and telehealth did count towards those global packages. And we use the GT and CR modifiers to help define this period of time of when those telehealth visits were happening. We did want to have some way of tracking later and looking at outcomes, and because of the way we bill for OB services in North Carolina, sometimes it can be a little tricky to figure out how to know which type of visit is which. Next slide. So we also turn on virtual telephone communications. I will tell you my personal bias is I don't like that as much as telehealth. I think the integrity of the medical visit is better when you can see your patient and evaluate different aspects of their physical exam, even on a video conference call. So we did turn that on. That was actually our first provision, was making telephonic and portal communication reimbursable. That was not reimbursable previously with Northgate. We did not go full parity with that, which created a lot of consternation, especially when Medicare went full parity on telephonic, and some of the commercial payers did as well. We ultimately agreed to go to 80% reimbursement, but we wanted there still to be incentive for practices to really move into the telehealth space and to challenge themselves and their patients, frankly, when able to use telehealth. Next slide. Oh, the other thing I'll say about the virtual and telephone communications is there are really specific guidelines in the CPT coding on if you've had a visit within a week, you can't have it, or if you have a visit within a certain number of days after, you can't bill for it. We waived all of those limitations. And so if somebody had a visit the next day or the day before, we still allowed them to bill that plus the other visits, because the limitations made it such that a lot of providers didn't really want to bill for these codes. So we stripped all that out by using those modifiers. Next slide. From the DME standpoint, we turned on a few things that we felt like were important for pregnant women. We made blood pressure monitors available as a DME order, which is not something that we did in North Carolina Medicaid before. We also made home scales, a DME product that pregnant women could access, and then also portable pulse oximetry for particularly people who were infected with COVID, whether it was COPD or asthma or other, and to give us one more little look at how the patient's doing if we're using telehealth and virtual care. Next slide. One of the things we did that I think is I'm really excited about, and I'm looking forward to seeing how the field responds to this, is a hybrid visit we created. So in medicine, we can do home health visits. I've loved doing them in my career. There's nothing better than driving out to a patient's home and seeing their physical environment. Unfortunately, to pay a physician to take that drive time and the visit time and the drive time back, you essentially block out a quarter or a half of a patient care day. And that's not very practical for the reimbursement rate. Yeah, the reimbursement's higher, but it doesn't justify that. Plus you have all that lost access to care. So what we did was we said, no, we're going to turn on telehealth. You can do telehealth with a hybrid visit where you can bill for that higher reimbursement home visit if you send one of your trusted staff members out to the home to do vital signs, to do any components of the physical exam for pregnant women, measuring fundal height or doing a urine dip or Dopplers, so that there's this combination of a staff member being in the home coordinating that real-time telehealth visit with the patient. And we felt like that had a lot of opportunity to allow for immunizations or blood draws or other things to happen in the home. And then the practice could bill for the reimbursement rate of a home visit, and then the staff time, it ends up being at least cost neutral, if not even revenue generating for them. Next slide. So we did allow postpartum depression screenings to occur via telemedicine, telephonic communication, as long as a portal communication was tagged in with an in-person or a telemedicine visit. Next slide. We also pregnant or delivered who are having lactation difficulties could do telehealth to get their breastfeeding support. You know, this was really inspired, and why didn't we think about doing this earlier? As someone who had a lactation consultant with my first kid, that taking that newborn out after a C-section, driving back and forth every day it was brutal. You know, to be able to do that by telehealth is a real service for the families anytime, regardless, and that's received really positive response. Next slide. In North Carolina, we have pregnancy medical home incentives where providers complete assessments of their patients at the beginning of the pregnancy and then at the postpartum visit that really judges their risk factors and helps us plug them into a care management algorithm. And those incentive payments are significant, they're fairly generous. And so we did allow that those pregnancy home incentive payments could be done with a telehealth visit. Next slide. Oh, and so that's it. So to say, I will say that one of our piece of learning we're in now is we made some assumptions about what we wanted to keep. So of the 367 or 70, whatever the number is, provisions we made, we want to keep about a third of the telehealth provisions, but we're starting to really look at the data and challenge some of our assumptions that we made about continuing things and seeing if, especially there's ancillary services, speech therapy, occupational therapy, audiology, optometry. Do we need to challenge ourselves on our assumptions on the utilization of those services with telehealth? So we continue to study that. All right, thanks very much.
Great, thank you so much. And as we continue these conversations about how states are utilizing, Medicaid waivers to better reach populations that you serve, and also, we're doing a lot of work around telehealth. Would love to thank MCHB for arranging for you to come join us today, and also look forward to hearing from other states in the future. But really, we know this is a really busy time for you, and we thank you for making yourselves available and sharing this really important information. Next, we will be hearing from Dr. Karen Rumley, who recently began as the director at the National Center on Birth Defects and Developmental Disabilities at CDC, but she is no stranger to state public health either. So, Dr. Rumley, I will turn it over to you.
Thank you, and thank you, everyone. Can you hear me, Amy?
We can.
I'm assuming everybody good. I just want to make sure. I always am worried if I pushed the right button. Michael, thank you for saying hello. And Shannon, what an amazingly wonderful presentation. And being in Virginia, North Carolina is our sister state. So it's always good to learn what you all are doing. As Amy said, I'm a pediatrician by training, but have been very involved in public health, was state health official here in Virginia, and learned a lot from the leaders in my maternal child health program, and actually was brought on when Governor Kane wanted to narrow the health disparities around infant prematurity in our state. And so now I have the incredible honor to be at the CDC, at the National Center for Birth Defects and Developmental Disabilities. I'm going to give you just some general updates about COVID today. And if there are any questions, hopefully I'll be able to answer them, or some of my other colleagues on the phone. The update for guidance for healthcare professionals on the care for children went live August 14th. This guidance received a lot of media attention, particularly focusing on the fact that rates in children had increased from May to July. I know that early in the pandemic, we weren't sure what the impact of children would be, but we have learned that children likely have the same or higher viral loads than adults. They can definitely spread the virus effectively in households and camp settings, and that 1 in 3 children hospitalized with COVID in the United States were admitted to the ICU. Children less than 1 year of age and children with certain underlying conditions are likely at increased risk to have severe COVID disease. Included abdominal pain in our symptoms list for children, and making recommendations about when to test, isolate, and quarantine for school-age children, and emphasizing the importance, as Michael talked about, of maintaining routine vaccination during this very difficult time. In addition, there were 2 updates to guidance that are on their way. They're in clearance. Hope they'll be live next week. One is for healthcare professionals on the care of breastfeeding women, and it reflects new evidence that mothers with COVID are unlikely to transmit the virus to their children through breast milk, and that pasteurization of donor breast milk may inactivate the COVID virus. We also made recommendations for infection control and prevention measures for lactation services. And there's additionally an update for guidance for the lay audience on pregnancy, care of the newborn with the mother with COVID, and breastfeeding, and that is in clearance. The main changes there will be an emphasis that mothers with COVID are encouraged, after discussion with their families and healthcare professionals, to room in with their newborns and breastfeed them while taking precautions. And then finally, updates to guidance for healthcare professionals on obstetric care during the pandemic are in the process of being drafted. This new guidance will replace the old inpatient obstetric guidance, include both inpatient and outpatient considerations for OB healthcare providers while caring for women with and without possible COVID during the pandemic. 2 interesting MMWRs that if you haven't read, you may want to look at. One on Friday was limited secondary transmission of COVID in a child care program in Rhode Island. I found it encouraging. The cases were limited to 29 child care programs in Rhode Island, 69% of which had a single case with no apparent secondary transmission. There were some cases of secondary transmission, but key to what we saw is context of in Rhode Island, the overall level of disease was less than other US states. And the secondary transmission was identified in 4 of the programs that have been allowed to reopen early when the community transmission was higher. So I think it has a big impact on child care programs, making sure the importance of wearing a mask by adults, limiting mixing between established student teacher groups, making sure everybody understands staying home when ill, and cleaning and disinfecting frequently touched surfaces. And, you know, at the end of the day, this is, as we know, just a really hard time for families, for child care staff, for teachers, for all of you who take on many different of those roles, along with the professional roles you have, as information about what we do with our families and our children changes as this pandemic goes on. And I will stop there, Amy. Thank you very much. And thank you again for welcoming me.
Great, thank you so much. I know that our members were going to be really excited to have heard from you today and continue the conversation. We'll have time for some more Q&A at the end. I specifically requested if you could please mention that Rhode Island Child Care MMWR, as I frequently talk about with having my own kids back in school. I'm always trying to stay up with the latest and greatest. And I will say that I mean, we've only been back for not even 2 months now. There's only one classroom that's had to shut down when there were some suspected, when there were some symptoms in one of the teachers. And, you know, that's the benefit of keeping these non-mixing groups together. You didn't have to shut down the school, and not that it didn't make a big impact on that classroom and their families, but, you know, we're all trying to do what we can to minimize the risk. That's what it's about, right? Next, I want to give a just brief acknowledgement. I know many of you joined us yesterday on the webinar that my coworkers hosted about, and some of our partners, about the RFP that we have out right now for our CARES funded telehealth and MCH work. So thank you for everyone who attended and asked great questions. Just a reminder that the letters of interest are due September 1st. The recording of the FAQ webinar that was held yesterday will be available later today. And then please visit our website, which is amchiptelehealth.org, or email us at telehealth@amchip.org if you have any further questions. And if there are some lingering questions from yesterday, Sabra and the telehealth team are on this call as well, so you can feel free to ask. Next, I am really excited to turn over to my colleague Paige Busenich from the Child and Adolescent Health team at AMCHP to facilitate a conversation with 2 students who have joined us about their perspectives on returning to school. So Paige, I'm going to turn it over to you. Great.
Yes, hi. Thanks, Amy. And thanks everybody. So we're really excited to have 2 students with us today. So these students are joining us from a program called College Steps, which is a hosted service currently at 11 different college campuses. College Steps support students living with learning, social, or communication challenges as they pursue a college education and other post-secondary goals. So with us today, we have Elijah Dawson. He's a recent graduate from Northern Virginia Community College. And while he was a student there, he was a part of College Steps. Elijah successfully transitioned from community college to a 4-year university and is currently enrolled at George Mason University studying communications. He is a new member of the ROTC program at George Mason and has the goal of becoming an Air Force officer. His hobbies are exercising, watching anime, and he is interested in learning how to drive a boat. Also with us today, we have Dianite Asmalash. She is majoring in general studies and also interested in English at Northern Virginia Community College. She has a goal to transfer to George Mason University or Marymount University. Her favorite hobbies are reading and writing, listening to music, and watching TV shows and movies. So I'm gonna ask our special guests some questions and then give them some time to respond to each of the questions. So the first question we have is, what are your thoughts on the considerations released by national organizations on the need for students to be in school physically this fall semester? Elijah, do you want to go first?
Sure, but just to be sure I got it right, can you repeat the question? I'm sorry.
No, absolutely, no problem. So what are your thoughts on the considerations that have been released by national organizations on the need for students to be in school physically this fall semester?
Okay, so my thoughts on that are because most schools in my area are only going by essential classes and labs, I think that they are handling their class schedules and physical presence by necessity well. I think that as long as, like in my ROTC course, I'm required to be there in person, I think that they're doing a pretty okay job to try and stay safe. But other than that, classes that aren't essential, like all of my other classes are just online. Those are my thoughts.
Wonderful. Thanks so much for sharing, Elijah. Dinite, would you like to add to that?
Yes. Right now, this is my opinion. We don't want, students to get COVID-19. We can't really go back to school in person unless we get a vaccine. And I feel like our students need to be safe until the coronavirus is over.
Thanks, Dinite. So my next question is around the actual setting in which you're taking classes this fall. So how does an all virtual college setting impact your educational and social goals?
Okay.
Elijah, yeah, great.
I definitely got this. So because my transition to all online learning was actually a bit more smooth than my peers, because prior to COVID, I had to have surgery and I lived very far away from my campus. So I already was doing a lot of online learning. My thoughts on it are how it impacts me. I am a bit more introverted, so I'm okay with being at home a little bit. And I would say for myself and my peers, online learning is a bit more challenging, yet I believe that by my peers, and a lot of them won't want to admit this, they'll say it's more the online learning, but I think it's actually more of the social aspect, that they want to party and have fun and be with their peers. Yet, they just won't say that. They'll be like, oh no, the online learning is definitely the harder part. And, honestly, honestly, I think that some of the schools should refund the students for all the events and stuff that they would do that requires a large gathering, because we're all just taking online courses. So yeah, for me, it doesn't as much affect my educational goals, aside from I have to be at ROTC. Other than that, I'm okay with it, and I know my peers are not.
Great, thanks so much for sharing that, Elijah. Dinite?
For me, I'm trying to adjust to an online learning because I'm more of a in-class person, like the person who has to take class at campus rather than online learning. But now transitioning to online learning, it's harder for me to do assignments and do discussion boards and posting them on Canvas or something. It's actually my first time doing it. Prior to COVID, I was more used to going on campus for class, and be in class and do my homework assignments at the library, and then I'll just turn it in. I can't now with COVID. I can't go out with my friends. I can't go to the movies. I can't go to the mall. I can't go to the bookstores if I want to, and I can't even go to Nova and see some of my friends there. My thoughts are, as long as we are COVID-19 free, and online learning for me is quite challenging, I would say, and I'm still adjusting to it since this is my first semester doing it. So, yeah.
Yeah. Thanks for sharing that, Dinite. And I think I can speak for probably most of the other public health professionals on this call that we're all experiencing the same thing as we're transitioning to working virtually. Many of us are attending conferences that are typically we get to see all of our wonderful peers once a year, and we're super excited to see them. So I think we definitely understand that challenge. Really appreciate you sharing that. So I think both of you touched on this a little bit, but do you have any other thoughts about sort of the potential to return to campus for the spring semester, and what would that look like to you? What would a successful transition look like to you?
Well, to me, especially with how our government not only has been run currently, but also has been run previously. I was actually discussing this with a group of friends a few days ago. They also are college students. We're in this big group chat. As soon as, lockdown is over, quote unquote, a lot of us are just still going to stay inside because we don't exactly trust officials on their word. I mean, all these cases, and I really respect your organization trying to further the safety of children, from what it sounds like. A lot of, we just don't trust how things are run. And yeah, a lot of us are going to stay indoors, even after lockdown, just to initially test the waters, if you would, and see how things are going. So once we all are definitely confirmed that we're safe to go, hey, we out and about.
Great, thanks for sharing that. Dinah, do you have anything else to add to that?
My thoughts are, as long as we are COVID-19 free and it's completely gone, we can come back to the school and do things that we can resume our lives as if before COVID-19 came into the US. But hopefully we need to be more prepared for the future if we get not just COVID comes back, but also more viruses comes into the United States. Because unexpectedly this year we get COVID-19 and a lot, and guess a lot of people are trying to be more prepared and stuff, and still learn and still having to do with social distancing. So yeah, and also being quarantined. So I think we need to prepare for supplies and be more aware of the risk is going to happen soon.
I'm
Great,
sorry,
thanks.
I just love that response. That was awesome.
Really great. Love that support too, Elijah. Great support for your peers. So we have a few minutes left, and I know that both of you prepared some questions perhaps to ask folks on the call. I'm not sure to the extent that folks might be able to answer them, but would love to hear any questions you want to ask the folks. So we have people on the line from all over the country, most folks working at the state public health level. I don't know, Elijah, did you want to ask a question to the group and see if folks want to chime in?
I mean, for me, I would ask, if there's strictly someone who does have the power to make change, I would ask how they are feeling about the way things are going, and how will they help, not even help, just how will they make a change? Because, even over the past few months, not all changes have been exactly helpful. So I would love to hear an answer on that. Sorry if I'm being too general.
No, I think, yeah, it's a big question. I wonder if we have any takers from the audience. I guess folks could either, just like we do with typical Q&A, if you want to chat in the chat box, or raise your hand, and then we can you can unmute yourself.
I'm wondering if I can chime in. Elijah and Dinah, thank you so much, because it's been really great hearing your perspectives. And what I'm hearing in Elijah's question, I don't mean to put words in your mouth, so correct me if I'm wrong, but from your answers to some of your own questions, I'm wondering if maybe some of our attendees can speak to measures that they've been able to take or think about implementing in order to regain that maybe trust and relationship, especially with young people, in order to make the communication of the messages that are so important, to make them most effective.
Yeah, so far you're not putting words in my mouth. You're good.
Good, thanks. Well, if anybody wants to take a stab at that, just feel free to unmute yourself or type into the chat box, or, maybe I'll start calling on people. So. No one's ready to share yet. Okay, still thinking about that. Are there other questions in the meantime?
I have I know I have 3 questions, but I'll try to ask them as fastly as I can. So I wonder how long the virtual online school will last across the country. That's the first question. The second is, when will we have more fast tests? And I was just talking with Andrew about the tuitions of school. Is it possible that our school can reduce tuition for classes, since this is a online learning and it's not the same as in person? So is it possible?
So I'm going to jump in on this one. This is Shannon, and this has nothing to do with my day job. So what you're hearing is totally opinion. My sister is a professor at a university in Alabama, and I like to, we go back and forth, and I like to point out that I'm the real doctor, and then she points out that she's the real doctor. But anyway, we were having one of our back and forths, and I was really kvetching about my son's tuition at UNC because he was going back to telelearning, and I was sort of raging at how much I was paying in college costs for this telelearning, and she gave me a very impassioned explanation from the professor's standpoint, that actually doing this telelearning for the professor's side is it takes them twice as much time to set up their classroom and the structure, and they have to redo all of their curriculum and things that they might have gotten into a routine with. Is all this additional work. And then on top of that, the things that drive revenue on a college campus when you're not in person are gone. And so things that they might make money off of, the Chick-fil-A's or whatever the things are on a college campus that might help offset the losses, those revenue sources are gone. And so it is this really delicate balance from the perspective of the person paying and saying, I feel like I'm getting less for my son's education, at Chapel Hill right now. And the school saying, yes, but we want him to be able to come back. We want to keep this built and alive so that as soon as he can come back, we're ready to receive him. And so it's just a very interesting balance. It's a great question. And I think it depends on which hat you're wearing, how you would answer that question.
Thank you. That must be a really interesting, perspective to be able to access, and especially when you're in your position as a parent with a student in college. And and I chatted this in the box too, but I've heard the same even from elementary school teachers. It's taking twice as long to prepare. I just had this conversation with my neighbor yesterday. She teaches 5th grade. And I asked her how things are going, and she said it's taking twice as long because I've been teaching for long enough that I can just walk in and teach, And now it's completely starting all over again and figuring out how you're going to keep the kids engaged in the virtual learning environment. And that's true. I mean, even with adult learning right now and the virtual conferences that we're attending, and how do you keep people engaged in that way as well? Any other questions from the panelists? Otherwise, I can turn it over if we have any questions from attendees for any of the panelists. And of course, we're also entertaining questions for anyone who's spoken today, as well as always welcoming more suggestions of topics that you'd like to see on future calls. We plan on continuing to hold these as long as there's interest. So, okay, we have a comment here. From Sabra at AMCHP, who's running our telehealth cares funded program. And she says, what we've learned from our environmental scan is that providers don't save any money and may spend more to provide telehealth. So it's probably similar with virtual education. But in telehealth, families often report higher satisfaction, which is not the same for online learning for students who choose to attend in-person school. And students greatly benefit from those on-campus opportunities. I think that really sums it up. I mean, I think what COVID has taught us is there's no good answers often. We have to really just try to do the best we can in this situation. Let's see. What question that we got from Jerry is, what has been your mental health or stress level like during COVID-19? And have you had experience with the use of telehealth? If so, what has it been like? Jerry, is that directed at anyone in particular?
No, either one. I just thought I would ask.
One of our students?
Yes, the students. Sorry, for the students, yes.
Sure, thank you. Have either of you used telehealth services?
So what exactly, thank you for asking, what exactly classifies as telehealth? Because like, when I think telehealth, from what I've had to do, I've only gone as far as to call my immediate care or call healthcare providers about insurance, or I need to make an appointment. I actually had to do 2 different physicals, and I'm also going to make an appointment for immunization. And I especially love that this discussion and what has been shared also was facing immunization. It reminded me about that. So that's telehealth to me. Is there a more correct way of viewing it, or am I on point with this?
I think I'm probably thinking about a more like a video, like a FaceTime kind of interaction with a provider. Sabra, if you want to jump in, feel free to go ahead.
Sure, this is Sabra Inkner. I think that in its simplest form, and of course with all evolving technologies, there's not like one definition, but essentially it's something that generally would be expected to happen in person, but is instead happening in a virtual format. So for instance, calling to make an appointment is something that you always do, right? You call and you make the appointment, so it's not replacing anything. But if you have that appointment where you get on a video chat, or as North Carolina example, in some cases, even just a phone call, and you have the entire appointment with your provider via that virtual method where you're not face-to-face, that would be considered telehealth. There's other things that, that go along with that, some communication platforms between providers. So if your primary care provider needs to, say, consult with your surgeon, and they exchange images and messages via some platforms to get that consultation, sometimes that can be considered telehealth as well. But for sort of the end user patient, it's generally, if it's a thing that would be reasonable to do in person with your provider, doing it virtually is telehealth. If it's a thing that you would never have done in person with your provider, then it's not telehealth, although it can be considered e-health or m-health or other really great technologies.
Okay, that definitely does clear it up. Thank you for that. And yes, I actually have had to make a few doctor appointments where instead of being in person we've had to do a video conference. And I would say only because I live a bit of a distance away from that doctor, it actually was a bit beneficial to have the video conferences. You know, we don't meet often. It's just that I live far away, and, you know, it's saved me in a bit of gas. So it's unfortunate we don't get to be in person, and sometimes, you know, I feel I don't get all the time I need, but it's worked out.
It's great to hear your perspective on that, and something that I think is really informative for the other telehealth work that we're doing. And so I hope states that are considering applying are thinking about that type of perspective. And so Jerry said it's another good thing to remember that sometimes the language that we use is not used as much by young adults and adolescents, and we need to think about that even when we're doing our messaging around telehealth or telemedicine, since those are increasingly common terms. And many of us who never utilize services in that way until this year are becoming more and more accustomed to it. And so again, another thing to think about for your applications for the AMCHP telehealth project.
Heavy facts.
All right, well, we have a couple minutes left, so I'm going to open it up if anyone has any other questions. Feel free to type them into the chat or unmute yourselves. Jamie points out youth might relate more to something like FaceTiming with your doctor. So, yeah. Do our students want to share anything about how your mental health has been during the time of COVID? And then we also have a question from Dr. Warren to Dr. Dowler. So first I'll pause and see if Elijah or Danae want to answer that question.
I've been talking for a minute, so if Danae wants to answer, that's cool. I actually do have a very, I have a bit of an interesting answer for this one, but I've been talking for a minute. I don't want to take time away from Danae.
No, you're not taking away all my time. I promise. How have they felt mentally? For me personally, and mentally, during COVID-19, I was, I really, I was really trying to adjust because when COVID came, I had to transition, like from in-class learning to online learning, and the transition was really hard. But during that time, I felt like it was quite a challenging to being quarantined, because you really can't do anything outside anymore as much as you used to until it's vaccine safe. It's safe to return to like the outside world and stuff. And I really didn't enjoy like COVID-19, because now I get like bored, stuck inside all day, like other than watching TV shows and movies and reading books, I felt like kind of bored because I couldn't go out and like hang out with my friends, go to bookstore, the mall, anything that I want to do. So I felt like it was quite challenging, but I was, adjusting to it. Even though how I feel about it, it kind of made me like go, I really didn't enjoy it. So
I have similar grievances about this, and actually my answer would pertain to how me and my brother actually have been using a video chatting app where you talk with random people. No, it's not Omegle. And everyone, like people all over the world, everyone, we talk to mostly people our own age, everyone has either brought up COVID and how they're under quarantine and they're affected very heavily and they're very sad about quarantine or not going out or just generally frightful of going out. So, and for my mental health, I'd say not much has changed. I'm very goal driven, and so far COVID hasn't gotten away of my goal. So my goal is to be an officer in the Air Force, and as long as I can go to my ROTC.
I'm going to turn over to Dr. Warren to pose a question to Dr. Dowler. I also want to, I don't think we're gonna have time to get to it. I wanna mention that Sarah posted a question in the chat box about adolescent pregnancy and potential increases. And I wanna suggest that this be a topic for another call because there's probably a lot to talk about there. And so, Sarah, I'm going to also reach out to you about this. But if other states want to reply to her, she did put her email in the chat box about this issue. And Dr. Warren, you're on.
Thanks. I guess for Dr. Dowler, knowing North Carolina, like many states, has so many areas that are rural and broadband access is a challenge particularly. How have you all navigated that? I realize that's not your primary responsibility, but it certainly impacts the ability of folks to access telehealth. So curious if there are lessons learned there, or things that you found that are successful.
You know what? I think it's possible that Dr. Dowler isn't on the call anymore.
Okay. I'll email her. That's no problem. Thank you.
Okay. You have her contact info?
Thanks.
Good. All right. Well, we can use another minute if anyone wants to respond to Sarah's question. If not, I'm giving you a preview. We're going to talk about this on a future call as well. Of course, don't forget our next call will be in 2 weeks on Thursday, September 10th. So register. Of course, if you register for this call, it should have also given you an option to register for future calls. And please do fill out the survey afterwards. It does help us make sure that we're on the right track, and we welcome any suggestions for topics or, questions that you want to have answered. So thank you again for participating again, and we'll see you again in 2 weeks. Stay safe and healthy. Thank you.
Have a great day. Thanks for having us.
Have a great day. Thank you.